Welcome to Legal Nurse Podcast. This is your spot to get inspiration, tips, stories, and guidance to help you in your legal nurse consulting practice. I'm Pat Iyer, the host of Legal Nurse Podcast since 2016. We are among the top 5% of all podcasts in the world in terms of longevity and sharing information consistently week after week with legal nurse consultants. Sit back, relax, and enjoy the show. Welcome to Legal Nurse Podcast. I'm Pat Iyer. We're going to focus today in our interview on one of the areas that is commonly involved in litigation, and that is the emergency department. There are commonly cases that arise in this area from the care delivered either by the doctors or the nurses or others. And in light of that, I brought to you today an expert in emergency department medicine, Dr. Stein, who has over 27 years of clinical experience in the emergency department and critical care units. He has been an expert witness for about 20 years and has been deposed and testified multiple times. He's very familiar with how we as legal nurse consultants get brought into a case, either to screen it for merit, identify experts, or provide testimony. Welcome to the show, Dr. Stein.
Good morning. Pleasure to be here. Thank you for inviting me.
You're welcome. I wanted to focus, first of all, in laying the foundation. As attorneys love to say, let's lay the foundation. What does the plaintiff attorney have to prove in order to make a case viable?
All right. So as you, the audience, know, as legal nurse consultants, there are four main parts or tenets of a med legal case. Number one, the duty, that there's a duty to serve the patient or treat the patient. And that's kind of implied if they're in the ER and you're caring for them in the ER. Number two is that there is neglect. The term we use in medical circles and in legal circles is that there's a standard of care and that there is a breach of the standard of care. And that's a term that's somewhat misunderstood. The standard of care is not the same as the gold standard. It does not mean perfect care. It can be average care. It can actually be somewhat below average care. Why do I say that? Well, if the bar that you put there as to what's acceptable says, well, anything less than average is unacceptable, that means that 49% of the medical care in America would be unacceptable. And that's a little bit too high. It has to be viewed as what's reasonable and competent care. It doesn't always need to be what is usually done, but it needs to be what's appropriate for that situation. So let me give you a true life example. I was in the intensive care unit, got called to a rapid response. Patient was in severe respiratory distress and had to be intubated. Unfortunately, the patient had severe kyphosis. What does that mean? It means their back is bent forward and their head in normal position. When this person was walking, they would be looking down at the ground. They were not able to lift their head up. I said, lower the bed back to intubate the patient. They lowered the bed back, but the patient's back was still curled forward and you could not stand behind the bed to intubate him. I was a former gymnast. I'm still somewhat flexible. I climbed on top of the bed, put my legs straddling the patient, and I had to go between my legs to intubate the patient. Is that normal? Is that usual? No. It was appropriate for that situation. So the standard of care is always patient and case specific. What was appropriate for that situation? You then have to show that there were damages, that something bad happened to the patient. So if someone prescribed an antibiotic, say penicillin, and the patient has listed a penicillin allergy, but there was never any reaction after you gave the antibiotic in the hospital, that might be inappropriate, it might be a breach, but there were no damages. Now, if there are damages, you then have to connect and say that breach, that act of negligence, so the doctor or nurse practitioner did something they should not do or did not do something that they should do, that was the cause of the damages. And it depends on what stake you're in. It could be that it was the cause, it was the major cause, or it was a contributing cause. So you have to have those four parts: the duty, a breach of the standard, damages, and a causation. And for a plaintiff's attorney to be successful, they have to show all four of those parts. Any one of those parts is missing, and it would not be a successful case.
Thank you for that explanation. That is very helpful. And I am envisioning the expression on the people in the room as you climbed up on the bed, straddling the patient. They would be sitting there saying, I hope he doesn't fall. This is an unusual thing to be doing.
Exactly. If you remember, there was a TV show back in the 90s, I guess, MacGyver. And MacGyver always had to find ways of figuring out how to do things with the limited resources he had on hand. We don't often do that in medicine, but sometimes you have to do what the situation calls for.
Yes, yes, we do have to be creative and inventive at times. As we think about the emergency department, the term handoff comes to mind. And first explain to our listener, what is a handoff? And then how does that occur in the emergency department? And how can that lead to gaps in communication?
Oh, sure. There are various types of handoffs. So the handoff basically means one provider is turning the care of the patient over to another provider and informing them with information. So if EMS gets called, 911 gets called to a patient's home, they're the first responders. They're there on the scene. They see what's going on. They bring the patient to the hospital. They then have to relay that information. So the triage nurse or the doctor, whoever they're handing the patient off to. And I'll just divert for a second. Do you remember the old game we used to play back in elementary school, or you may have played telephone?
Yes, very well.
15 or 20 people in a line, and the first person gets a message, and they have to turn over their shoulder and tell the next person. And by the time it gets to the last person in the line, it may be a totally different message. The same thing, unfortunately, can happen with healthcare, that there are miscommunications. So something's told that wasn't quite accurate, or there might be pieces of information that are missing. So one turnoff might be from EMS to the nurse and triage. The triage nurse will then give information to the primary nurse in the room. The doctor or the resident or the nurse practitioner walks in the room, and the treating nurse will then give information to them. If the patient's admitted, the admitting team needs to be contacted. The consultants need to be contacted. And of course, anywhere along in this continuum, it might be the magic hour of 7 o'clock in the morning or 7 o'clock at night, and it's change of shift. And then everyone who is there is giving information to the new crew. And of course, not every bit of information is going to be given. So there's always the chance that important information may fall through the cracks.
And we all know when that information falls through the cracks, then there's a high risk of patient injury.
Yes. There are sometimes systems that some of the electronic medical records can have a handoff document that people can use to give information. But even with that, you can't give 100% of every activity that happened that's gone on with the patient or every lab result. And that's a high risk area for medical litigation, is at the time of handoff of mistakes that have occurred.
And I know that the Joint Commission, which accredits many of the hospitals in the United States, identifies miscommunication as the number one cause of medical errors. When I think about written communication and I think about medical records that I have reviewed over the years from emergency departments, they've ranged all the way from handwritten notes to checkoff boxes on templated forms to electronic medical records. How does the documentation system support communication or foster, again, miscommunication?
So The electronic medical record is a system, it's a tool that can that can help us. It can also cause us great difficulty and stress at times. Um, it helps to capture tons of information. All the lab results are there, the vital signs may all be included there, but then you can also get what we call chart blog, where if a patient has been in the hospital, say it's in the intensive care unit, and they've been there for 2 weeks, you may have 15 pages of past lab results and radiology results that come up in the record. And if you have that in your note, you're implying that you're aware of all those results. But there may be a lot of information there that you're not aware of. And the next person who comes on, they're not going to read all 15 pages of the notes necessarily. So that can be one area. There's also what are called templates. They can also be called dot phrases or smart phrases. The reason they're called a dot phrase is if you're putting in your note, you might say dot physical exam, and it is a template that will be inserted into your note of your physical exam. It may save you a lot of time using these templates for a procedure note, for cardiac risk factors, for discharge instructions. But what's important is to make sure that you look closely at your template and say, well, is it appropriate for this patient? So for example, I had a note I was reading by another provider, and it says patient with severe anoxic encephalopathy after cardiac arrest of 30 minutes on mechanical ventilation sedated. But then in their templated note, it says patient is alert and oriented times 3. So there's a lot of information that you may have in your template, but please be careful if you're a provider to look at those. And if you're a legal nurse consultant reviewing things, are there things that don't make sense? So if it says patients alert oriented times 3 and they're comatose, that one section of the template may be inaccurate. It raises the question, are other parts of the template accurate or not?
I know that the rush in the emergency department is the productivity, the production. Let's get people in and out as quickly as possible. And I'm aware of cases where the results of diagnostic testing come in after the person has left. Can you give us some insight about that scenario and how that could result in liability?
Okay. I am smiling because I am thinking of a specific case that occurred about 20 years ago. A physician's in the emergency department, and they are very fast. They get people in the rooms, they get people out of the rooms. And for that reason, administration really likes that person. A patient came in, was in 3rd-degree heart block, and that ER doctor was fast. That ER doctor called up a cardiologist and said, patient's in 3rd-degree heart block. There was a room available in the cath lab. They immediately whisked that patient off to the cath lab, put in a pacemaker, permanent pacemaker. Then the lab results came back, and it turned out the patient had hyperkalemia with a potassium of 7.5. They corrected the hyperkalemia. The patient no longer was in complete heart block, but now they had a permanent pacemaker, which was not needed. So there's a lesson that we teach all medical students and residents, which is never order a test or an x-ray if you're not going to look at the results. And what happens sometimes is many of the results will come back while the patient's in the ER, the troponin, CBC, chemistries. But there's some tests that might be a send-out. Say, for example, you ordered a PSA, prostate-specific antigen, for whatever reason in the ER. Or they're blood cultures that come back later. There needs to be a system in place where when those results come back, that someone is going to be responsible for looking at them. If it's a patient that you're sending a send-out test on, and they have a primary care doctor or they're being admitted, the provider would need to relay to the primary care provider or whoever, please, you're going to be responsible for looking at the results of these tests that we ordered. For blood cultures, hospitals will generally hopefully have a policy that when they come back, if it's from the ER, they'll bring the results to the emergency department An ER physician or a nurse practitioner will look at the results, decide if it's pertinent. If it's pertinent, then contact the treating provider if they're admitted. If they're sent home, contact the patient, advise that they come back or talk to their primary care doctor, have it taken care of on this outpatient. The same sort of thing happens with x-rays. A lot of times at nighttime, the ER doctor might be the one looking at the films. You can tell I'm old when I say looking at the films. We used to actually hold films up to a board and look at them. Now we look at them on the computer. And the emergency medicine physician will give their preliminary opinion. Or there's what we call a Nighthawk service, a teleradiology, where they're looking at it and they give their preliminary opinion. The patient gets admitted or gets discharged, and then the next day, the official result comes out. If there's a discrepancy, just like with blood cultures, the hospital needs to have a system in place of how those are followed up. And there are numerous cases where that leads to medical negligence cases and damages. An example would be what's called and this is not only a late result, but often a result that might be buried in the body of a report. And by the body of a report, I mean the main part of the dictation. And then at the end are the final impressions. And sometimes physicians or nurse practitioners may only look at that final impression section and miss that in the body of the report, it says there is a 2 centimeter spiculated mass or opacity in the right upper lobe. Recommend follow-up imaging. So there's something that's abnormal. It may not be related to the car accident the patient had, but it's very pertinent and needs to be followed up on. So these are some of the areas where delayed results or missed results that were there in the text can be very important and lead to medical negligence claims.
I want to break down a few of the things that you said. You talked about the Nighthawk or the teleradiology service. Could you explain to our listener what that means?
Sure. For example, say the doctor is working in a rural hospital, small community. They do not have a radiologist of their own there. There may be a radiologist who's located somewhere else in that state or overseas in Australia or in England, looking at those images on a computer screen. And they will be giving their interpretation of those films. So Nighthawk is one company, but there are numerous other companies that do that. We call it teleradiology because just like a telephone or television, they're looking at the screen and they're doing radiology. So you can have teleradiology, telepsychology, teleneurology. We had telemedicine visits during COVID, and some of us still do.
Okay, thank you. When you mentioned the incidental finding of the mass in the lung, should that radiology person interpreting that bring that into the impression as well as, here are the things that I found, and oh, by the way, make sure that you include this as one of the things that you find that person has found in that film?
So ideally, that is what a radiologist should do. Is that the standard of care that would, once again, be case specific, but ideally and importantly, they should be. And generally, it's considered that a radiologist would put those important findings that need to be followed up in the impressions.
And one other question that is, well, two other questions. One of them is, what are you seeing in terms of AI being used to make some of these initial evaluations of films?
So currently I've stepped away from clinical care. So I am not seeing that because I'm not in the ER currently, but I was just at the American College of Emergency Physicians National Conference, and there are numerous companies out there that have AI radiology services where they will look at a CAT scan or a chest x-ray, pick out abnormalities. As to how that plays out in the court system and what's considered the standard of care, that's going to be determined, and it's a changing field.
It certainly is. And one other thing that strikes me is when there are significant findings and somebody in the emergency department makes that call to the patient, we all are using cell phones that very helpfully tell us who's trying to reach us. And many of us ignore calls that we don't recognize the phone number. I wonder how many times healthcare providers are trying to reach patients and patients are not getting the messages. Like you've got something growing in your blood, you need to follow up with your doctor, or your x-ray shows a hairline fracture, you need to see your doctor. Are you aware of situations where that has fallen through, that the patient has not gotten those messages, at least in the initial attempt?
Oh yeah, I've had several cases where that's happened, and it's problematic. Sometimes patients don't leave the right phone numbers for various reasons. It's important, depending on how significant the abnormality is, to try and call the patient. Often they may have an emergency contact number, and then the question is, how much information can you give to that other person other than to say, it's important that we have your contact information listed. Can you please contact Mr. Smith, have him call us back as soon as possible. There was a case where a patient had a very significant, emergently life-threatening abnormality that was picked up the next day and wasn't picking up the phone. And in cases like that, it may even be reasonable to call the police and say, hey, can you please send someone over to this house, ask them to pick up the phone or call us back. If you have a primary care doctor, which unfortunately many people do not, you can call the primary care doctor, let them know the abnormalities and say, please try and get in touch with the patient. But it can be problematic.
Mm-hmm.
And as far as what is and is not safe to send in text messaging, that's a whole area that attorneys will be looking at.
Yes. I've been involved in several cases where the attorneys got the phone records and were able to look at text messages that were sent and received to a particular cell phone, and that becomes evidence of the chronology of events.
A case I recently was looking at, it was a question of a nurse said that she called the doctor's office on 5 different days trying to arrange for an antibiotic prescription to be sent for a patient, and it wasn't. The doctor's office said, we never got any phone calls from them. So that's an area we're looking at. Phone records might be very helpful.
Yes. I know the concerns often are when a patient leaves the emergency department, perhaps test results were inaccurately interpreted, or there was an inaccurate diagnosis. The patient comes back to the emergency department 24 hours later, still sick, again gets dismissed. How does that play into your interpretation when you have cases like that as an expert witness, of looking at the sequence of events? How did it end up that the patient came back 2 times or 3 times, or maybe went to a different facility hoping for a different response?
Bounce backs are when a patient was discharged from the emergency department and then comes back. There is an excellent series of books actually titled, I believe it's titled Bounce Backs, written by Michael Weinstock, Emergency Medicine, and goes into detail looking at bounce backs and then the legal cases that have ensued afterwards. So when a patient comes back to the ER, sometimes the response a physician may have is, or a nurse practitioner, I just saw you here. Why are you back? And it may be somewhat defensive, and unfortunately, sometimes may be somewhat dismissive. What's an important way of viewing it is the patient is giving you another chance to get it right. And it's helpful to try and put on a different pair of glasses, look at things from a slightly different view to see if there's something that may have been missed the first time. It's a big area of problems when patients bounce back. What was going on? Is it the same complaint? Did the complaints get worse? Is this a normal progression that was expected if they were diagnosed with pneumonia, for example? Or is something changed? is it possible that now that you're seeing that it's not the normal progression, that perhaps your initial diagnosis was wrong? Or if you're another doctor and you pick up the chart, there's a tendency, and I believe it's called, forgot the exact term, but it's a bias based on what has already been diagnosed. It's often said one of the biggest impediments to getting the correct diagnosis is already having a diagnosis. So people say, oh, they have musculoskeletal chest strain after playing football, and they forget to think, oh, maybe it's a myocardial infarction, or maybe it's a thoracic dissection. Diagnostic momentum. There you go. That you just kind of go with the diagnosis that was given and you keep going. It's important to take a breath, look at things anew, see what's different, see if things were done right the first time. But it is a big problematic area and is an area for people to look at. Was it appropriate for the patient to be discharged the first time? Were things appropriately reevaluated when the patient came back?
I know you've reviewed cases for many years as an expert. What are some of the most common reasons or medical diagnoses that can give rise to liability?
All right.
People who are brought into the emergency department.
So there's a mix between what are the most common ones that where there might be a breach of the standard, and there might be other ones that are the bigger ones, that what we call the major high-risk ones that are very large dollar values. If they're lost and to a patient may be catastrophic or deadly. So the biggest areas those fall into are missed diagnosis. So someone comes in and, for example, chest pain, and we talk about the big three potentially devastating conditions that may be causing the chest pain. And those include acute coronary syndrome or myocardial infarction, pulmonary embolism, and thoracic aortic dissection. Now, that does not mean that every patient that comes in with chest pain needs to have a CT angiogram to look for dissection or pulmonary embolism, but you have to at least think of it, and then we put things onto a balance. How likely is a diagnosis? How risky is it, or how potentially dangerous is it if it's missed? And balance your workup based on that. So failure of diagnosis is one big category, and then failure to treat or delaying treatment. Failure to diagnose a posterior circulation stroke, and then you're not able to give the patient the proper treatment because you didn't make the diagnosis. Or a delay, that a patient comes in, has signs of sepsis, it's not picked up, it's diagnosed too late, and then you have delay in treatment. Some of the big high-risk categories that are more common than you see lawsuits for are stroke, myocardial infarction, aortic either dissection or aortic aneurysms that are leaking or ruptured, sepsis, meningitis, spinal cord infection or compression, or spinal nerve roots that are compressed, such as cauda equina. Another big one that's being seen more in legal cases is spinal epidural abscess, pulmonary embolism. Those are some of the big ones. Some of the ones that may not be as severe but are more common are missed fractures, for example, or soft tissue infections.
When you go through that list, I think about all of the damages and the permanent changes that people can experience if they survive those conditions. Cauda equina in particular, I think, is clinically one of the most horrifying conditions to think about. Paralysis and incontinence, and it can happen in a young person who's got a horrible quality of life afterwards.
Oh yeah. So one of the things, just to talk about cauda equina syndrome, or I'll put it in the same category. There's a compartment syndrome, and they have various criteria if you have a complete cauda equina syndrome. So you may have weakness, paralysis, paresthesias, incontinence of bladder, incontinence of stool, sexual dysfunction. And some people may have the mindset that, oh, you need to have all of those for it to be called equine? Well, no, it may be partial depending on how big the bulge is. If it's a disc that's protruding at L5, S1, is it totally compressing the nerve roots? Is it only partially compressing them? Same way with compartment syndrome. We talk about the 6 Ps of compartment syndrome: pain, pallor, pulselessness, paresthesia, poikilothermia, that means it's somewhat cool. You don't necessarily, paralysis. You don't need to have all of those for it to be a compartment syndrome. You would actually like to diagnose it before it gets to the paralysis point.
Great point. In light of all those serious complications that can be seen in the emergency department, attorneys are looking at medical records for language such as Dr. Stein ruled out this, Dr. Stein ruled out that. Tell us about the implications of the term ruled out, and are we changing that terminology at all?
All right. So the implication when someone says, I have ruled out, let's say pulmonary embolism, it means I have excluded it. It is not pulmonary embolism. And it is often difficult for many conditions to 100% rule them out. You get into what's called a risk-benefit analysis. What are the benefits of making the correct diagnosis? What are the risks or harms of missing that diagnosis? And then also, what are the risks of over-testing? Does every single person that comes in the ER that has any chest discomfort get a CT angiogram of their chest and a full set of troponin levels? So you have to kind of weigh the balance. There are also risks of testing. You may end up doing testing or ordering lab work and finding a lab abnormality that may not be pertinent, but may lead to hospitalization, further testing. There's also the risk to society as a whole. If we did a CT angiogram on every single patient that came in the ER, our waiting rooms would be packed. We'd never get anyone through. Plus, there's the whole financial cost to patients and to society. So there's a risk benefit. So the whole concept comes up of what is an acceptable miss rate. And that depends on the condition and depends on who you ask. So for example, our commonly used scoring system is called the PERC rule, PERC. It stands for Pulmonary Embolism Rule Out Criteria. And you can go to a medical calculator online, such as MD Calc. I don't get any money from them or anyone else, which is a wonderful resource. And you can plug in the different questions that you ask the patient, 8 different questions. And if you have a pre-test probability of a low risk of pulmonary embolism, what does that mean? It means you think in your mind, hey, maybe it's pulmonary embolism, but I don't really think so. And you do the PERC rule and it comes up negative on all those questions, they have a less than 2% chance that it's a pulmonary embolism. Doesn't rule it out 100%. So what some people are starting to say is, instead of saying I ruled it out, because then attorneys will say, well, did you absolutely positively rule it out? We talk about, I went from it being on my list to being a probability or possibility to now saying it is very unlikely that it is pulmonary embolism, very unlikely that it's meningitis. So I expect that over the years, we'll be seeing more of that terminology change from have ruled out to I have determined that it's very unlikely that this is the diagnosis.
It's interesting how our litigation system influences our documentation as we think more proactively about, could I be under the microscope at some point in the future over what happened to this patient? I've seen it in OB cases as well, where the language has been shaped by all the litigation of how certain conditions and terms are now being described as a result of looking for that black and white interpretation when we know that there's often a lot of gray in determining diagnoses and treatment. And the other gray area that we run into, and this is the next to the last question I'll ask you, is the patient has been identified as needing to be admitted and is in a hallway or down the hall, around the corner in a room. Who's in charge of that patient while they are waiting for a bed in that facility or to be transferred?
This is a very common and unfortunately very stressful situation referred to as boarding, such as if someone was in a boarding house, they're being boarded in the emergency department. And depending on the service, for example, psychiatry at many hospitals, patients needing inpatient psychiatry services, they may be in the ER for 1, 2, or 3 days, which is not a great situation if they need psychiatric care. So it's very problematic. While the patient is in the ER, a decision has not yet been made to admit the patient. It's the care providers in the ER physician or nurse practitioner, physician's assistant, the ER nurses. Once a decision is made to admit the patient, as ER physicians, we prefer that it be the admitting team. We have contacted the admitting team. The admitting team will come down and see the patient. They will write orders. That is our preference. That doesn't always work, and it depends on the hospital and what the hospital's protocol is and staffing. Some places it will be that the ER will continue to follow the patient, write the orders, order the tests that need to be done, have someone get up and walk the patient if they need physical therapy. But that often overwhelms the ER, which is already under a great amount of stress and burden. Many hospitals will have the admitting service, the hospitalist or whoever it is, come down, see the patient, write the admitting orders. And whenever the nurse needs something, if it's non-emergent, they will go ahead and contact the admitting service. If, however, it's a patient who's there who all of a sudden develops an emergent situation, they're now severely short of breath or severe new onset chest pain, it would be appropriate for the nurses caring for the patient to contact the provider who's right there in the ER, ask them to look at the patient. The provider may say, hey, I'm going to go look at them. Why don't you also, while I'm looking at them, call the admitting team? But it can be problematic in a bit of a gray area.
Boy, is that complex. Wow. In the ideal world, once the decision is made to admit them, they go right upstairs to a bed. But clearly that doesn't happen.
No, and unfortunately, it does not look like it's going to be getting better anytime soon.
I have a relative who had a severe stroke who spent 4 days in an emergency department in Maryland. We were unable to get him transferred to Johns Hopkins or to University of Maryland because it was during COVID and the ICUs were full. And he ended up really being very uncomfortable for 4 days. The beds in the emergency department certainly don't have the same kind of mattress as in a regular unit, and it was really hard for him and his family.
No. So one of the other points relating to your prior question about emergency medicine and, may I be sued at some point for my care, is that also leads to what we call defensive medicine. Sometimes people ordering many more tests than are really necessary, and even recommending procedures that may not really be necessary. A interesting anecdote from when I was in medical school. I was on my pediatric rotation and was seeing a mother who had just given birth, and it was by cesarean section. And you're a third-year medical student, and you ask, why would you have the baby by cesarean section? Was there a problem? And she said, well, no, I'm a medical malpractice attorney. And I looked, and I saw that there were many more successful cases against physicians when they did not perform a C-section when they should have. So I told my gynecologist, I want you to perform a C-section for what was otherwise a totally normal pregnancy.
Very interesting. I've talked to plaintiff attorneys. In fact, I talked to one yesterday who said, none of my physicians know what I do for a living.
Reasonable.
How can our listener find out more about you, your services, contact you about reviewing a case? What would be the best way for that to happen?
Oh, sure. Well, one, thank you very much for having me here, and I'd be delighted if any of the listeners would like to contact me. If that's about a case, initial phone call insults are always free. My website is pretty easy to remember. It's ER, like emergency room, dash or hyphen MD. So it's er-md.com. My email is Kenny Stein, followed by the number 1. So KENNYSTEIN 1 @gmail.com. And I've practiced emergency medicine, critical care medicine, also internal medicine certified, review for both plaintiff and defense, and it'd be a pleasure to assist you if I can at all.
Thank you very much, Dr. Stein, for sharing your expertise. I know that there are many other aspects of what we could have gone into today in terms of the liability issues in emergency departments. It certainly is an area of healthcare that is under fire for many reasons, many aspects of delivering care in a high pressure, highly intense environment.
Yeah, when I started working there, I had a full head of hair.
Yeah, and look what happened. Yep, I can appreciate that. For you who's been listening to this podcast, please go to podcast.legalnursebusiness.com. Check out the resources that we offer you. You can get copies and links to past programs, transcripts, audio and video files when available, all organized so that you can find what you need when you need it. And hang on for just a few more minutes to find out who's coming up next on Legal Nurse Podcast. Subcontracting can make or break a legal nurse consulting career. In this episode, I share powerful stories from pulling medical records out of a dumpster to managing hundreds of subcontractors. I reveal both the risks and the rewards of this model. You'll discover what subcontracting really means for LNCs, how it offers opportunities for growth, and where it can go wrong if expectations aren't clear. You'll hear firsthand lessons from subcontractors who learn to say yes to opportunities, adapt quickly, and grow their skills under guidance. I also offer candid advice for independent contractors, how to train, manage, and supervise subcontractors so they deliver quality work without damaging client relationships. Through these insights, you'll gain a realistic picture of what it takes to succeed in subcontracting roles. Whether you're a new LNC seeking experience or an established consultant ready to expand, this episode gives you practical strategies to help you decide if subcontracting is the right path. Learn how to dive deeper into this topic by getting both volumes of LNC Success at lnc.tips/LNC Success both. I'll see you on the podcast. Thank you for being part of the Legal Nurse Podcast audience. I'm delighted that you've joined us for this episode. Be sure to go to legalnursebusiness.com and get your free reports. Look around the website, pick up some tools that will be useful for you in your legal nurse consulting practice, and be sure to join us for the next episode.